Understanding and Preventing Cognitive Errors in Healthcare.
Why didn't I catch that sooner? I know better. I should have realized what was happening.
You know, we've all had experiences like this, in which there's a delay in diagnosing or treating something, and we feel we should have been able to understand it earlier. The problem is that being wrong feels the same as being right, up until the moment we recognize that we were wrong all along. That's because of a process called sense-making.
What does sense-making really mean?
Sense-making is simply figuring out what's going on, but this figuring out process is dynamic. Our first impressions influence what we pay attention to or minimize, and that influences what and how we think next. This is why actions that seem right in the context of understanding at the time then become incorrect as our understanding changes. This video is intended to provide tools to assist in the recognition and earlier recovery from thought process errors, which are also called cognitive errors, that occur during sense-making.
What do you mean by cognitive error?
Cognitive errors are mistakes due to thought processes themselves, rather than a lack of fundamental knowledge or data. In a way, they're similar to illusions. You may have seen this famous illusion before. Although the bottom line appears to be longer than the top line, we can measure and confirm that in fact they are the same length. But even after we know they are the same length, our brains still see the bottom line as longer than the top. This perception is visually irresistible, but it may be overridden by deliberate cognition.
Wait a second. What do you mean by deliberate cognition?
Well, we make decisions using a dual process model. Type 1 processes are intuitive and automated and use very little mental effort. We almost can't help but see the bottom line as longer than the top. Type 2 processes are deliberate and analytical and may be used to override or adjust Type 1 decisions.
So which is better, Type 1 or Type 2 processes?
We need both. We make decisions more quickly and with less information in Type 1 mode, which has obvious advantages during critical events with high-stakes outcomes and time pressure. But Type 2 mode is needed when we should engage in a thorough evaluation of choices. We can make mistakes with either mode, but we make more cognitive errors in Type 1 mode. Because those processes are largely subconscious, errors made in Type 1 mode are often unrecognized and left uncorrected.
So can you give me an example of a cognitive error?
Sure. A shark attack makes for a very vivid and memorable newscast, and you may easily recall that story the next time you visit the beach. This causes you to overestimate the risk of a shark attack, which fortunately is quite rare. This illusion of probability, which is really just memorability, is termed availability and represents Type 1 thinking. When actual probability differs from perceived probability, this is a cognitive error called availability bias.
Does availability influence our medical thinking too?
Absolutely. You might know the phrase, when you hear hoofbeats, think of horses, not zebras. This is intended to emphasize that common things are common in order to focus our thinking on likely options, while de-emphasizing rare possibilities. Mental shortcuts like this allow us to be more efficient by avoiding lengthy consideration of every possible option. And because common things are indeed common, this shortcut results in diagnostic accuracy most of the time.
That sounds like a good thing. I thought we were talking about errors.
Right, Sarah. Availability gets us the right diagnosis much of the time. However, just like shark attacks, remembering vivid but rare cases can cause availability bias in medicine too. For example, an emotionally charged personal experience, like a patient dying in the OR, or a powerful vicarious experience, like a highly publicized error, are both quite memorable. But in both cases, memorableness is high despite the probability of future recurrence of a rare event actually being quite low.
Are there more examples, Marjorie?
Yes, there are dozens of heuristics, biases, and other thought influencers that may lead to cognitive error. You've probably experienced a few of them yourself. For example, fixation error describes the tendency to focus on one problem or diagnosis while losing track of the complete situation. It's easy to get fixated on a frustrating task, such as troubleshooting a malfunctioning infusion pump, and lose track of vital signs or blood loss. As another example, visceral bias describes how our emotions may impact our decisions when we care for a VIP patient, a vulnerable child, or a patient perceived to be difficult in some way.
What can we do to prevent cognitive errors from resulting in actual medical mistakes?
One technique is to regularly practice the Rule of Three strategy. This is a mental auditing process intended to prevent us from allowing our type 1 thinking to go on unchecked. This rule specifies we should explicitly consider and rule out 3 alternative diagnoses, even if all evidence seems to agree with the first one that came to mind.
So Marjorie, if our patient is having a surgery with a risk for occult high-volume blood loss, we are intuitively and appropriately worried about severe hemorrhage as the cause of suddenly deteriorating vital signs. But, like you said, we sometimes need to shift from type 1 intuitive to type 2 analytic thinking. Actually, those original 3 signs of hypotension, hypoxemia, and tachycardia, depending on the other data that we find, could fit several different diagnoses.
Similarly, we should reconsider the problem when we find ourselves repeating the same therapeutic maneuver 3 times. For example, a fluid bolus for hypotension is often an appropriate first-line therapy, and it's usually reasonable to repeat it once or twice. But if we're on the 3rd bolus and thinking about a 4th, it's time to reconsider. Are we using the best therapy? Could the correct diagnosis be something else? Or perhaps we really are on the right track. If you regularly practice the Rule of Three strategy during routine decision-making, it will come more easily to you during challenging decision-making.
That's right. One of the clues that should trigger us to reassess our data and diagnosis is if our patient is not improving as expected with the usual treatments. When we summarize aloud all available data, this helps us to reassess, both for any changes in data and to ensure our mental model is both accurate and shared with the team. Marcus Rahl coined the term 10 seconds for 10 minutes to emphasize the value of a pause to reassess and summarize all data, preferably verbalized aloud with a team including key data and explicit diagnosis. As we list the gathered data, it may become clear that an alternative diagnosis fits better than our first impression, or that there is a second concurrent, potentially iatrogenic problem making the patient worse. A related strategy is to purposefully seek disconfirming evidence. After thinking of alternative diagnoses using the diagnostic Rule of Three, we can actively check for multiple pertinent positives and negatives that would not support our first diagnosis, but do fit with an alternative diagnosis. We rescue ourselves from intuitively but perhaps inappropriately filling in the data that our brains expect for our initial diagnosis. As we seek out pertinent data that support an alternative diagnosis and actively notice pertinent data that may not fit with our first impression, we hone a more accurate mental model. And when the pieces are not fitting together or something just isn't right, it helps to ask the team, could this be anything else? Are there other strategies that you want to share, Marjorie?
Yes, there are several. One important strategy is to pay attention to circumstances that may promote biased decisions or otherwise foster cognitive error. We can do this by asking ourselves some of the following questions. Was the diagnosis suggested to me by the patient or by a colleague? Did I consider causes besides the obvious one? Is this a patient I do not like or like too much for some reason? Have I been interrupted or distracted while caring for this patient? Am I stereotyping the patient or the patient's presentation?
Any other favorites?
Another favorite strategy of mine is called prospective hindsight. This can be thought of as a diagnostic timeout, in which we deliberately pause our thinking and imagine finding out later that we were actually wrong right now. Then we examine the current situation for cues that would later be identified as the red flags that were missed. You know, we've all had the experience of listening to another person tell a story of an event gone wrong. And when we're the observer, it's easy to see the unfolding error as predictable or obvious. The purpose of prospective hindsight is to try to harness that benefit of hindsight in the present moment.
But Marjorie, often during an emergency, there isn't time to just stop and think.
Sometimes that's true. When your patient is worsening, but you feel too busy to do a diagnostic timeout, consider calling for help. Helpers can take over physical tasks, but they can also help us think through the diagnosis and treatment choices. But you're right, Sarah. Sometimes we've done everything we can think of and the patient is still getting worse. Any suggestions?
Emergency manuals containing context-relevant checklists or cognitive aids can be valuable in helping all of us to deliver best care to our patients. In rare events, like suspected malignant hyperthermia, in refractory events, like hypotension that is worsening despite all the usual measures, or in complex events, like the many H's and T's of pulseless electrical activity, emergency manuals can help us manage the case better. So, in any emergency, let's give immediate treatment to our patient, and when resources allow, be sure to consult an emergency manual. See the How and When to Use Emergency Manuals video for more tips. When events become critical, remember also to call for more help and use effective teamwork strategies.
So, next time you hear that tiny voice inside saying something's wrong, consider using some of these techniques to avoid cognitive error.
Use the rule of 3. Summarize aloud. Seek disconfirming evidence. Ask your team or expert helpers, could this be anything else? Consider, are circumstances biasing your thinking? Try prospective hindsight. Consult an emergency manual.